ठीक आहे. Today's topic is the benign connective tissue tumors. So, soft tissue tumors or connective tissue tumors is a complex of non-epithelial extraskeletal structures of the body exclusive of the supporting tissue of the various organs and hematopoietic tissues. So, soft tissue includes fibrous connective tissue, adipose tissue, skeletal muscle, blood and lymph vessel, peripheral nervous system, mostly derived from the mesoderm with a neuroectodermal contribution. So first, we'll see what is the normal structures, that is the fibrous tissue, which consists of the fibroblast, extracellular matrix, fibrillary structures like collagen and elastin, ground substance, IC reactive for bimental and actin. Next is the adipose tissue, which is of two types, white fat and the brown fat. White fat are the which consists of round or oval cells, contains large lipid droplets. Crescent-shaped nucleus is pushed to the periphery and seen in subcutaneous tissue or the abdomen. Then the brown fat is a smaller cells with a centrally located nucleus, acidophilic multivacuolated cytoplasm. It is also having the nucleus which shows the fine indentations. Mitochondria are numerous and seen in neck and mediastinum. Skeletal muscles, which are derived from the myotomes, develops from the mesoectoderm in head and neck. Myoblast from the myotubules, which consist of myofibrils. Myofibrils contain actin and the myosin filaments. Next is the blood vessels, which is of two types of cells, endothelial cells and pericytes, or smooth muscle cells. Endothelial cell contains pycnotic new vessels, Weber palate body, von Weber factors, and pericyte shows cytoplasmic microfilaments, thick continuous basal lamina. Next is the peripheral nerves, which are formed by the axon, Schwann cells, perineural cells, and the fibroblast. Coming towards the benign connective tissue classification, benign tumors are classified into predominantly the fibrous tumors, fibroma, giant cell fibroma, nodular fasciitis, fibrous histiocytoma, xanthoma, juvenile, xanthogranuloma. Then the tumors containing the fat are the lipoma and lipoma variants. So first classification contains it is a fibrous tumor, that are the fibroma, very important one, giant cell fibroma, nodular fasciitis, then the fibrous histiocytoma, then tumor containing the fat are the lipoma and the lipoma variants. Next is the neurogenic tumor, that is the schwannoma, solitary neurofibroma, neurofibromatosis. The neuromas are classified into fibrous neuromas, palisaded encapsulated neuromas, multiple endocrinal neoplasia syndrome 3, and granular cell tumor. Myogenic tumors are the rhabdomyoma and leiomyoma. Lymphatic and vessel tumors, lymphangioma, hemangioma, very important one, the hemangioma, arteriovenous hemangioma, juvenile capillary hemangioma, cavernous hemangioma, nasopharyngeal angiofibroma, hemangiopericytoma, and the carotid body. Malignant tumors are classified into hello. Fibroblastic malignancies, fibromatosis, fibrosarcoma, malignant fibrous histiocytoma, malignancies of adipose differentiation, liposarcoma, and neurogenic malignancies are classified into malignant peripheral nerve sheath tumor, olfactory neurofibroblastima, and neuroblastoma. Myogenic malignancies are again classified into rhabdomyosarcoma and the leiomyosarcoma. Vascular malignancies are the angiosarcoma, corpuscle sarcoma, malignant hemangioperipheratoma, malignancies of uncertain histiogenesis, alveolar soft part sarcoma, synovial sarcoma. Coming towards the first benign connective tissue tumor, which is of the fibrous tissue origin, that is the fibro. This classification of benign connective tissue tumors or the malignant tissue tumors can be asked as a SQ question. Whenever the LQ question is asked, you have to mention the classification first and then describe the next oral pathological condition. So first condition of the benign connective tissue tumor is the fibrosarcoma, which is also known as the irritational fibroma, traumatic fibroma, focal fibrous hyperplasia, or the fibrous nodule. The peripheral fibroma is a reactive hyperplastic mass that occurs on the gingiva and is believed to be derived from connective tissue of the submucous or the periodontal ligament. Remember the point, it is believed to be the connective tissue of the periodontal ligament. So, etiological factors, because of the local irritations like excessive restorations or the improper restoration. Then next can be a presence of any root piece or cracked occlusal surface of a tooth, or maybe a denture, or maybe a any kind of irritation which is present in a oral cavity. Also trauma from the biting of the cheek may occur at any age. Female develop these lesions more commonly than do the males. In gingiva, its occurrence is the gingiva anterior to the permanent molars is most often affected. So clinically, as either a pedunculated or a sessile mass that is similar in color to the surrounding connective tissue. Most fibromas are 1.5 centimeter or less in diameter, always a well-defined lesion and symptomless. So this is the main description of the fibromas, which is having a small swelling, which is measuring from 1 to 1.5 centimeter. The color of the swelling is very similar to the adjacent normal tissue. Also, the swelling is pedunculated one or the sessile one, and this swelling comes under the heading localized type of swellings. So see the pictures. You can see fibromas on a tongue. Histopathology. So histopathologically, you can see the nodular mass of fibrous connective tissue, which is having dense and collagenized connective tissue, radiating circular or haphazardly arranged, varying number of fibroblasts, stretched epithelium with flat ridges, lymphocytes, and the plasma cells. So presence of lymphocyte and plasma cell is very important finding. So as this tissue is of the flat fibrous tissue origin, so you are gonna see more dense and collagenized tissue, also the radiating circular or haphazardly arranged varying numbers of the fibroblast. The slide is there in the department, so you can have this slide for 5 marks in the practical exam, and if they ask as a SAT question as a fibroblast. So this is the picture of histopathological picture of the fibroma, in which the atrophic overlying epithelium is seen. Underlying tissue is showing the connective tissue with dense bundles of collagen fibers and fibroblasts and the fibrocytes in varying numbers. Next entity is the fibromatosis. which represent a group of infiltrative fibrous proliferation, biological behavior and microscopic appearance intermediate between the benign lesions and the fibrosarcoma. Fibrosarcoma is the malignant tumor. So proliferative lesion of the connective tissue, non-neoplastic spindle cell proliferation, juvenile aggressive or desmoplastic one, which represents as firm, painless mass, exhibit rapid or insidious growth, most common in paramandibular soft tissue regions. Histopathologically, this proliferation of fibrous tissue is of poorly circumscribed, mature fibrous tissue with abundant collagen, highly cellular tissue, fibroblast may contain 2 to 3 nuclei. Very important finding regarding the fibromatosis. Normal mitotic figures and some cellular and nuclear pleomorphism can be seen. Clinical behavior and the management. Oral fibromatosis affect mainly adults. Oral lesions are common in children. Recurrence rate is 25 to 65%. Wide excision is advised. Prolonged follow-up is necessary. Next lesion is the giant cell fibroma. It is a fibrous hyperplasia with distinct clinico-pathological features. Etiology, chronic injury or irritation, virus-induced one, common in first 3 decades of life, female predilection. It is again asymptomatic, sessile or pedunculated one, usually less than 1 centimeter in size. Surface of the mass often appears as a papillary growth. 50% of all cases are seen occur on the gingiva. The mandibular gingiva is affected twice often as the maxillary gingiva. The tongue and the palate also are the common sites. So histopathologically, the covering epithelium often is thin and atrophic, although the radi ridges may appear narrow and elongated one. Loose fibrous tissue is present. The hallmark of the presence of numerous large stellate fibroblasts within the superficial connective tissue. Important finding, you can see this fibrous tissue or in giant cell fibroma, the stellate reticulum-like fibroblast cells, which are having several nuclei. Large plump multinucleated fibroblasts. This is the important finding regarding the giant cell fibroma. That's why the name is given as a giant cell. Next important entity is the peripheral giant cell granuloma, or you can call it as a PG3G. Common tumor-like growth. Origin is the periosteum or the periodontal ligament. Dispute etiology, reactive or neoplastic process. Reactive nature is more supportive. Local irritation, etiological factors. Local irritation due to plaque, calculus, ill-fitted dentures, etc. Clinical features, presence as red, blue nodular mass. Very important, the color of the lesion, whereas fibroma is having same color at same adjacent normal tissue color. But here in peripheral giant cell granuloma, it is having red blue nodular mass, sessile or pedunculated, involves gingiva or alveolar process, 4 to 6 decade of life, female predilection, and mandibular gingiva is more common involved. So location wise, so all these tumors or localized swellings or localized benign connective tissue tumors, all they are will have the very similar structures regarding the clinical features. That is, their size is similar, that is 1 to 1.5 centimeter. Then they always present as a sessile or pedunculated one. Next, their their location is the mandibular gingiva or mainly the canine premolar region, or they are always present anterior to the molars. Histopathologically, non-encapsulated connective tissue stroma, mesenchymal cells, ovoid or spindle shape, common mitotic figures, and important finding this peripheral giant cell granuloma As the name suggests, giant cells, that means the multinucleated cells are present, hemorrhages and hemocytin pigments are present, and spicules of posterior or bone is present. So the name is given as peripheral giant cell granuloma, that means it is present peripheral areas, that is at the soft tissue areas. Central regions means what? Central regions means they involve the bone, but it is not involving the bone. That's why it is named as a peripheral lesion. So peripheral lesions contains the soft tissue tumors or soft tissue lesions only. So in this peripheral giant cell granuloma, you can see above lining is the epithelial lining. Then the normal connective tissue with wide blood vessels and the presence of hemocytin pigments, which are brown in color. Next, below that, there is the presence of various shape of the large cells, that are, they may be oval, elongated, circular, or any shape, and they contain more than two or several dozens of nuclei. So the range is from 20 to 100 nuclei within these each single cells. That's why they are known as the multinucleated giant cells. So this is the picture of peripheral giant cell granuloma. The similar slide or the same slide is present in our department. So practical exam, you will cover 5 marks for this identification and the drawing of the diagram. So peripheral giant cell granuloma schematic presentation. Next entity is the peripheral ossifying fibroma, which is a common reactive gingival growth, pedunculator or sessile mass on gingiva, predilection for maxillary anterior region. 50% of cases interdental papilla is involved. Children and young adults, second to third decade of is involved. So it appears as a nodular mass, either pedunculated or sessile one, that usually emanates from the interdental papilla. The color ranges from red to pink, and the lesions are less than 2 centimeter in size. Radial origin, histopathologically, the basic microscopic pattern of the peripheral ossifying fibroma is one of the fibrous proliferative association with the formation of mineralized product. So exceeding cellular connective tissue, delicate fibroblastoma, plump proliferating fibroblast, several forms of calcification can be found. So as the name suggests, peripheral ossifying fibroma, the important finding is this, the trabecular
मम्मी वहाँ पर चला मन जाते
So trabecular or laminar bone. Bone is oval and trabecular in type. Cementum-like material or dystrophic calcification are characterized by multiple granules, tiny globules, or large irregular masses of basically mineralized material. Occasionally, giant cells are seen. So peripheral ossifying fibroma will show they are the only the ossification or trabeculae of laminar bone present in a connective tissue. So this is the schematic presentation of peripheral ossifying fibroma. Pyogenic granuloma, common tumor-like growth of oral cavity. Their etiology is the benign neoplasm, reactive lesion due to the chronic irritation, poor oral hygiene, history of trauma, or heterogenic irritation. All these are the etiological factors. The growth is accelerated by nitrous oxide, VGF, FGF, then pyogenic granuloma is seen up to 5% of pregnancies. So the hormones may play important role. Clinical features: smooth or lobulated exophytic lesion, pink to red purple, asymptomatic and the painless one. Histopathology: highly vascular proliferation, numerous small. So histopathologically, highly vascular proliferation, numerous small, large, enjoyed blood vessel channels are present. Plum mitotic active endothelial cells are present, surrounded by pericytes. Plum mitotic active fibroblasts are present. Neutrophils and lymphocytes in a edematous stroma. Origin of the giant cells. Many theories are given. First is the odontoblastic theory, origin, or second one is the endothelial cells of capillaries is the origin, or osteoclastic is the origin. So giant cells can be derived from sorry for the baptizing granuloma can show capillary blood vessels and scattered. The distribution histological features of common reactive hyperplasia of gingival connective tissue collectively designed as a list. Most lesions are thought to be reactive or the chronic irritant. The first lesion we have seen fibroma, which is of the hyperplasia of supraperiosteal tissues resulting in an overproduction of dense collagen. So first tumor, which is important, that is the fibroma, where you have seen the overproduction or the dense collagen fiber bundles and numerous fibroblasts in varying sizes. Next one is the next one was the peripheral giant cell granuloma. Here there is a hypoplasia of periosteum resulting in the overproduction of a vascular component and the mononuclear and multinucleated giant cells resembling the osteoclast. So in peripheral giant cell granuloma, origin is again same, but histopathologically you're gonna see the multinucleated giant cell. Next one is the peripheral ossifying fibroma. Here the hypoplasia of periodontal membrane resulting in a cellular lesion consisting of fibroblast and the collagen and cemental or bone deposits. So bony trabeculae is seen. And last one is the last one is the pyogenic granuloma. Here, the hypoplasia vascular component of connective tissue results in a cellular lesion composed of endothelial cells and small capillaries. So, fibroma, peripheral giant cell granuloma, ossifying fibroma, and pyogenic granuloma. All these are very similar looking lesions. Clinically, they are showing the very similar areas, location wise are similar, then their location is similar, their color is similar, their appearance is similar. Only thing is that they differ in their histopathology. So central giant cell granuloma is a central. Next variant, next benign connective tissue tumor is the central giant cell granuloma. is a central osteolytic lesion characterized histologically by multinucleated giant cell in a background of ovoid or spindle-shaped mesenchymal cells. Whether central giant cell granuloma is a reactive lesion or a truly benign neoplasm remains undetermined, and the mechanism determining the onset of the disease remains unknown. It is thought to be due to organization of slow, minute recurrent hemorrhages and is characterized by osteoclast-like multinucleated giant cells with vascular stroma and new bone formations. So clinical features: young patients under 30 years, important one, young adults. Female to male ratio is 2:1. Mandible anterior parts commonly crossing the midline. This is the significant finding of the central giant cell granuloma, that is, it occurs in mandible and mainly the anterior part, which crosses the midline. No signs and symptoms. Accidental finding may cause expansion of cortex and performation, mobility, displacement, and root resorption of the associated with borders of the lesions may be regular one or the diffuse one. Clinical features: depending upon the clinical and radiological features, it is of two types: aggressive one and the non-aggressive one. Non-aggressive ones are the slow growing, no root resorption or cortical performation, newborn formation, and the aggressive ones are the which grows quickly, cortical performation, and the root resorption and the pain can be seen as a clinical feature. So radiological features: radiolucent area with ragged or relatively smooth border, often multilocular one, cortical plates, often thin and expanded and may be perforated one. The displacement of the adjacent teeth can be seen, appearance not pathognomic one. So reducing area with either a relatively smooth or ragged border with definite loculations. Cortical plates are often thin and expanded and may become perforated by the mass. Fuzzy densities and wispy opacifications might be seen within the radiolucent areas and are thought to represent mineralized trabecules. Root resorption may be seen. Smooth or scallop margins may also be evident. Most of the lesions are multilocular one and well delineated, majority having non-corticated. So radiolucent area with ragged border, radiographical finding. Again, radiographically, you can see a multilocular radiolucency which is crossing the midline. The borders are scalloped one. Pathogenesis or the gross pathology is unknown, suggested that results from the organization of slow minute recurrent hemorrhages, often history of trauma, cystic lesions of the bone can be associated with, twice of frequent in mandible and maxilla, particularly in the anterior region. Histopathologically, this central giant cell granuloma will show the loose fibrillar connective tissue with many interspersed proliferating fibroblasts and small capillaries. Collagen fibers are not usually collected into the bundles. Groups may be present in a whorled pattern. Large number of osteoclasts like multinucleated giant cells are present. Patchy distribution: cells may contain few or several dozens of nuclei. Rather, a cellular vascular stroma, often the osteoid or new bone formation evident at the periphery of the lesion. So you are not gonna see the epithelium here. You are going to see only connective tissue stroma with presence of collagen fibers. Then the collagen fibers, multi multinucleated giant cells, and the presence of osteoids. So you can see in various shapes and sizes of the multinucleated giant cells over then the circular one, elongated one, or irregular in shape. And the giant cell. Presence of giant cells can vary from 20 to 120 in number. Then the presence of fibroblast in a connective tissue stroma and the collagen fiber bundles. So central giant cell granuloma shows a dense mass of multinucleated giant cell resolving the root of the, and in histopathologically they are showing multinucleated giant cells in a vascular stroma which contains plum spindle shaped cells and the hemorrhages. Next entity is the central ossifying fibroma. It is a rare encapsulated neoplasm consisting of highly cellular fibrostroma in which bone cementum-like spherules or combination of both occurs. So these tumors are non-malignant but locally aggressive one. It is believed to arise from pedial or peduncular ligament, which has potential for both osseous and cemental differentiation. This explains the presence of oval or laminar bone and curvilinear cementum. It occurs in third to fourth decade of life. Females are more affected, more common in blacks, mandibular inferior to premolars and molars. Maxilla, canine fossa and zygomatic arch. Smaller lesions are asymptomatic and as the lesions enlarges, they produce a unilateral painless swelling leading to a facial asymmetry. So radiographically, you can see the lesion most often is well defined and unilateral. Depending upon the amount of calcification of the material produced in the tumor, it may appear completely radiolucent or more often varying degrees of opacity. Growth tendency tends to be concentric with outer expansion of bone equal in all directions. The lesion is seen well circumscribed with smooth contours and well-defined borders. This demarcation of the bone from the surrounding tissue is very important in distinguishing this tumor from the Ferrous dysplasia. So, scattered, irregular shaped, bony trabeculae and calcifying spherules with the background of variety of avascular cellular fibrous tissue. This is the characteristic features of central ossifying fibroma. So many delicate interlacing collagen fibers, rarely the bundles are seen, interspersed by numerous active proliferative fibroblasts, many small foci of irregular bony trabeculae. As the lesion matures, islands of ossification increase in number and enlarge and ultimately coalesce. So proliferating fibroblasts and foci of calcification are the two important findings of the central ossifying fibroma. These trabeculae are having different shapes and sizes, oval and the circular or the irregular one. Presence of osteocytes in these trabeculae, and these trabeculae are importantly presence of osteoblastic rimming. These are the differentiating points